Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing benign prostatic hyperplasia, or BPH. And the reason we're discussing this topic today is that this is a condition that affects many male patients, particularly older age male patients, and this disease state, which is essentially an enlarging of the prostate, can cause significant reduction in terms of quality of life and reduction in normal activities of daily living, such as regular urination. So learning objectives for today will be to describe the anatomy and physiology of the bladder and the prostate, to talk about causes, risk factors, and symptoms of BPH, to discuss medications pharmacologically that are used to treat BPH, as well as other non-pharmacological options regarding BPH, and then to discuss specific interventions to be made in BPH in certain patients. Our case today is MM. He's a 68-year-old male who presents to the primary care clinic with complaints of urinary dribbling. He's had these symptoms over the last few months and feels as if his bladder is full. Physical exam and additional testing reveal MM has BPH. An AUA symptom index reveals a score of 8. MM's prostate is measured to be 30 grams and his PSA is 0.9. So what type of BPH does MM have? Does he have mild BPH, moderate BPH, severe BPH, or does MM not have BPH? Second question, what intervention would be most appropriate for MM at this time? Finasteride, oxybutynin, prostatectomy, or taurursine? And what is an adverse effect of the agent chosen in question 2? Is it dry mouth, eye discoloration, gynecomastia, or hypotension? And after discussion of this topic today, you should be able to answer each of these questions with confidence. So a little bit of background about BPH. Essentially, prostate disorders involving enlarging of the prostate actually are broken up into 3 essential different types. We have what's most commonly known as BPH, or benign prostatic hyperplasia, but we also have other classifications such as benign prostatic enlargement and benign prostatic obstruction, also known as BPE and BPO respectively. Now, whenever we refer to BPH, most people will just refer to BPH, but remember that BPH may also be intertwined with these other classifications as well. BPH typically develops in about 80% of older men, with the peak incidence around 63 to 65 years old. Symptoms are very uncommon in patients who are less than 50, so younger patients tend not to get BPH unless there are other factors that are at play. It is present in about 78% of male patients 80 years and older, and this is essentially more or less because of natural processes that are going in our body that cause enlargement of our prostate, which we will discuss in a little bit. 50% of symptomatic patients actually require treatment, and that is obviously dependent on the symptomatology of our patient and how severe that symptomatology is, and we'll also talk about how we grade our symptoms in regards to BPH. So a little bit about the anatomy and physiology of the prostate. A normal prostate gland in males weighs about 50 to 20 grams, and if you use a density of 1 gram per ml, like standard water, that's about 15 to 20 milliliters. It's very important to be aware of the size of the prostate, because size of prostate may actually dictate what drug therapies we choose for our patient. The 2 major functions of our prostate are to secrete fluids to make 20 to 40% of our ejaculate volume that patients may actually ejaculate during orgasm, during sexual activity. And it also provides secretions with the antibacterial effect, and this probably is related to the high zinc content of the prostate and the high zinc concentration. Just to give you a little bit of background about how the prostate develops over time in males, at birth the prostate is actually only about 1 gram, and it remains this size until puberty. Once puberty happens, and over time during the period after puberty, it grows to a normal size to about 15 to 20 grams by ages 25 to 30, and remains this size until the patient is 40 years old. So prior to the patient becoming 40 years old, the prostate is actually, in most patients, normal size, and that's why we don't see BPH in a lot of patients who are under 40 to 50 years old. However, once the patient hits 40 years old, a second growth spurt occurs, and that growth spurt essentially continues in regular growth for the rest of the patient's life. Therefore, the prostate is constantly increasing and can essentially quadruple in size or even grow larger. And as you see here with the anatomy of the prostate borders the bladder and surrounds the urethra completely. So when urine is emptied from the bladder, it goes into the urethra, which at the first part of the urethra, the prostate actually covers. And so if the prostate is becoming bigger in these cases, or more constricting and not as relaxed as it used to be, it can actually inhibit urinary flow and cause patients to have symptoms of either increased urination, increased urine frequency, or decreased urination and decreased urine frequency, depending on the size of the prostate and exactly how much urine is in the bladder at that time. To give a little bit more background about the prostate's made of different types of tissues: epithelial tissue, stromal tissue, and a capsule. An important point to think about is to remember that testosterone and dihydrotestosterone, also known as DHT, are androgens, and these promote epithelial tissue growth. The stromal tissue and capsule actually contain alpha-1 adrenergic receptors, with about 65 to 75% of the stromal tissue being alpha-1, alpha-1A receptor specifically. And if you remember your alpha receptors, there are about 7 different types of alpha receptors, alpha-1A being one of them. Whenever these alpha-1A receptors are stimulated by norepinephrine, it causes smooth muscle contraction and therefore compression of the urethra, reduction of the urethral lumen, and decreased bladder emptying. So antagonism of this pathway, which is a target of one of our drug classes, can actually reverse these symptoms, or basically minimize these symptoms, such that increased bladder emptying can occur. In regards to etiology of BPH, we have to think about static factors and dynamic factors. In terms of the static factor, the factor that stays the same with BPH is the anatomical enlargement of the prostate. So the prostate size is essentially preventing the outflow of urine potentially from the bladder area. There's a physical block at the bladder neck, and therefore urinary flow is obstructed here. Now, in terms of dynamic factors, excessive alpha adrenergic tone of the stromal tissue of the prostate may promote contraction of the prostate gland around the urethra. And as a result of contraction of this prostate gland here, you may actually have a narrowing of the urethra occur because the prostate is compressed around it, and that may also minimize urinary flow as well. And if you think about it, the drugs that we have available that we'll talk about shortly target the anatomical enlargement of the prostate, or essentially reduce the prostate size, and they also act as alpha agonist, certain drugs, in regards to treatment of the BPH. So it's important to keep these factors in the back of your mind whenever you're thinking about the BPH treatments and what they're actually used for. In regards to clinical symptoms of BPH, or benign prostatic hyperplasia, these are divided into obstructive and irritative symptoms. And these symptoms overall are known as lower urinary tract symptoms, or LUTS, L-U-T-S. In regards to obstructive symptoms, these occur with reduction of bladder emptying. So essentially, because of the blockage that the prostate is having over the urethra, the patient is not able to properly empty their bladder. So patients feel very hesitant to empty their bladder. They might be straining, they may have urinary dribbling, because not all of the urine is able to empty the bladder. And as a result, the bladder feels full because it's just essentially obstructed. The urine cannot flow out. We also have irritative symptoms, and these typically happen later in the disease course. Um, this can consist of involuntary bladder contractions triggered by small amounts of urine in the bladder, and this can lead to increased urgency and frequency. So basically, you might have a patient who has their urine full. You might actually have your patient with a relatively empty bladder, and as they're having these bladder contractions are just basically occurring because a small amount of urine is in the bladder. Your bladder has become very reactive to any amount of urine that is there and tries to push it out. And as a result, you're going to have increased urgency and frequency that you may see, even in terms of some patients who may have things like urinary incontinence. As a result, patients may have nocturia or urination in the nighttime, and the bladder may eventually wear out or become hypertrophic or hypertrophy, and become ineffective at emptying urine, which is not what we want for patients. And in those types of patients where the symptoms get severe enough, they may actually require surgical intervention. In terms of diagnosis, there is a multifaceted diagnosis for BPH. We assess medical history, we assess medication history. We want to check for any offending agents that are present. We will also do a digital rectal exam on the patient to examine the prostate. We will look at a voiding diary. If a patient has done a voiding diary or has previously been examined for their urinary symptoms or BPH symptoms before. And the voiding diary essentially is a way to tell us as clinicians basically how their urinary symptoms have been. So basically, they will tell about the quality of their urinary symptoms, how many times they've had urinary symptoms during the day, maybe how many times they've gone to the bathroom. Urinalysis, and we'll look for things such as hematuria, urolithiasis, or a stone, as well as infection, because any time that extra fluid hangs around in the bladder, for example, that fluid has propensity to become infected, and we don't want that for any patient. We will look at something called the prostate-specific antigen, or the PSA. Part of this is to screen for prostate cancer, but part of it also can be done to assess need for further drug therapy. Other tests can be done, such as bladder emptying tests done with a device called a uroflowmeter. And this essentially measures how quick the urine is leaving the body. Usually low urine flow rates of less than 10 to 12 milliliters a second indicate failure of bladder emptying due to obstruction or detrusor muscle dysfunction. A lot of times we might actually look at a post-void residual volume, and this is assessed with an ultrasound. So basically, in the bladder area, we'll look to see how much urine is left in the bladder after a patient goes to the restroom. And if a patient has a high volume, more than 25 to 50 milliliters, that may imply impaired bladder emptying. Usually whenever we go to the restroom to urinate, you should not have any residual volume left in your bladder. So any kind of residual volume that is left there is basically indicating that there might be some obstruction there that is causing that urine to stay there, such as obstruction that the prostate may have. And obviously, anytime that you have urine staying in a place for a long period of time, it can become infected and grow bacteria, which is not good for the patient again. We also assess symptoms through a system called the AUA symptom score or index. The AUA symptom score index is also known as the American Urological Association symptom score / index. And the disease severity is classified into 3 different categories. Once you have a diagnosis of BPH, you are basically broken down into a score. So lower scores are actually better. For patients with a score of 7 or less, that indicates mild BPH. And a lot of times these patients end up being asymptomatic. They may have low urine flow rates and possible post-void residuals of greater than 25 to 50 mLs. But at this point, a lot of these patients actually end up not being very symptomatic, or they may be asymptomatic. In regards to patients with a score of 8 to 19, these patients are considered moderate BPH, and these patients may have obstructive and or irritative voiding symptoms, such as detrusor muscle instability. So these are the patients who may actually benefit from an intervention like pharmacotherapy. Usually with mild BPH, we don't do treatment, though in some patients it may be indicated, but most of the time, if it's mild and asymptomatic, we tend not to. In patients with severe BPH, that correlates to a score of greater than or equal to 20. And that will correlate to all of the above symptoms plus 1 or more other complications of BPH. And we'll talk about the complications shortly. So this is what the index actually looks like. And it basically asks the patient questions over the last month. So it asks them all these questions on a Likert scale, and they can rate themselves from 0 to 5 on each of these 6 questions. Now, remember, obviously, the higher the score, the worse off the patient actually is. In terms of our treatment goals, we want to control symptoms of our patients, so we want at least a 3-point decrease in that AUA symptom score index. We want to obviously prevent the progression of BPH, and we want to reduce the complications, and those are the complications that you may have whenever BPH becomes severe. So if BPH becomes severe in its later stages, you can see patients develop acute or chronic kidney failure, and this is because of the obstruction of the urinary outflow. You might see them develop hematuria or blood in the urine. They may have overflow urinary incontinence. They may have recurrent urinary tract infections because of all of the fluid just hanging around in the bladder area. They may have bladder stones because of things that are hanging out there, and they may have even something called bladder diverticula, which is essentially development of a pouch in the bladder that actually is not supposed to be there. And that can cause its own set of problems. So you don't ever want to have that happen to your patient. And you don't really want any of these complications to happen to your patient. In regards to treatment options, we have a variety of different treatment options that are available for treatment of BPH. Those include our alpha adrenergic agonist, which are basically the cornerstone of a lot of our BPH treatment. We have our 5-alpha reductase inhibitors, our phosphodiesterase 5 inhibitors that we are also learning about with erectile dysfunction. We have anticholinergics, and then we have our beta-3 adrenergic agonist. In regards to non-pharmacologic therapy, we have options of minimally invasive surgery and prostatectomy. So this schematic from DePiro is very important for you to know. In addition to all of the bolded information in this PowerPoint, the bolded information is particularly important information, as is all information in this PowerPoint, but I want you to focus for testing purposes a lot on this schematic that you see here from DePiro, as well as all of our objectives that we have. So this schematic here will be very important when choosing selection of an agent or agents for BPH. Now, in regards to patients who have mild symptoms, what we tend to do with those patients first is what is called watchful waiting. So if you have mild symptoms, remember that is a score of 7 or less on the AUA score / index. And we just want to reassess these patients every 6 to 12 months. Most of the time, these patients don't need actual pharmacologic therapy unless it's really bothering them. And if it bothered them that much, they would most likely have a higher score on this index. Some things that you can counsel patients about in regards to BPH are restricting fluids close to bedtime so that we minimize the risk of nocturia, minimizing caffeine and alcohol intake, which are some of our just natural diuretics on their own. Empty bladder during daytime hours as frequently as you can. Don't hold in any extra fluid if you don't need to, and if you're able to go to the bathroom, go to the bathroom. Make sure that you're, urinating as fully as you can. Avoid medications that can make voiding worse. So obviously we know that there are a lot of medications out there, particularly those anticholinergic medications, which may potentially worsen some particular symptoms of BPH, particularly if we already have a full bladder. And there is a actual role of these agents in BPH as well, as we'll talk about a little bit later. And we also want to reassess prostate size and PSA, which again is a surrogate marker of prostate enlargement, because if the prostate continues to grow bigger, it will continue to obstruct the urethra and essentially prevent proper bladder emptying. In regards to patients with moderate symptoms, the treatment is broken out into 4 different subgroups depending on whatever fits your specific patient. So if you have a patient who has erectile dysfunction, for example, we're going to use an alpha adrenergic antagonist, a phosphodiesterase 5 inhibitor, or both for these patients. And as you see here, alpha adrenergic antagonists are essentially the cornerstone of therapy for moderate symptoms. But first of all, we're going to talk about our phosphodiesterase 5 inhibitors, which we talked about with erectile dysfunction. In regards to BPH, tadalafil or Cialis is actually the one that we see the most used in BPH, and the reason why is because of its duration of action. If you remember from erectile dysfunction, tadalafil actually works for up to 36 hours at a time for the purpose of erectile dysfunction. And because it has the longest duration of action of the phosphodiesterase 5 inhibitors, and because BPH is a chronic disease state, that is why tadalafil is predominantly used. The reason we use tadalafil in patients specifically with BPH is it relaxes smooth muscle in the prostate and bladder neck through cGMP increase. And it essentially will improve some of your voiding symptoms that a patient may be having. The dosing of tadalafil specifically for BPH is 5 milligrams by mouth daily. They looked at the other dosings, and basically they found that the 2.5 dosing is not as effective. The 5 dosing is effective, and whenever you go higher than 5, you actually see more incidents of adverse effects. Now, obviously, we want to keep tabs on all of our adverse effects that we see with the phosphodiesterase 5 inhibitors, particularly facial flushing, dyspepsia, headache, congestion, dizziness, hypotension, and rarely priapism, or essentially prolonged erection, which is essentially the same adverse effects that we had on the slide from the erectile dysfunction lecture. Remember that these agents are contraindicated with organic nitrates such as nitroglycerin, nitroprusside, isosorbide formulations. If you are using another type of phosphodiesterase 5 inhibitor such as sildenafil or vardenafil, for example, or avanafil, you'll want to hold nitrates for 24 hours after giving those PDE5 inhibitors. You can use the other PDE5 inhibitors for BPH, but again, because tadalafil has the longest action, it makes the most sense to use tadalafil. But remember, in terms of the contraindications for the nitrates, if you are giving tadalafil, that you need to wait at least 48 hours because of its longer duration of action. Because those patients, if you give them a nitrate, will become hypotensive. So do not give nitrates and PDE5 inhibitors. And if you have to, you need to space it out appropriately, as you see here. We also obviously have our alpha-1 antagonists, and these are the cornerstone of therapy for BPH patients, particularly with moderate symptoms. These are divided into second generation and third generation, and you see they are bolded here. These are generations that I want you to know. Second generation includes terazosin, doxazosin, and alfuzosin, and third generation includes tamsulosin and silodosin. The alpha-1 antagonist relax the intrinsic urethral sphincter and prostatic smooth muscle, which enhance the urinary flow from the bladder. So remember that we have all those alpha-1A receptors on our prostate, and they essentially can promote contraction of that prostate. We essentially want to promote relaxation of that prostate so that urine can flow out of the bladder properly. These agents do not reduce prostate size, as you will see with the 5-alpha reductase inhibitors that we are about to get to. What is very important is that the third generation are specific for alpha-1A versus the second generation, which may be non-specific. Alpha-1A is important because alpha-1A is specific for the prostate tissues versus alpha-1 receptors, which we have in the body, particularly in the vasculature. So as a result of having alpha-1 receptors in multiple places in the body, if you give a non-specific agent, such as those of the second generation, we're going to see adverse effects more so with those agents. And because we have alpha-1 in the vasculature, we're going to particularly see hypotension. We're going to see syncope, or essentially faintness, and dizziness with these patients, because essentially these second generation will lower the blood pressure. It's not seen as much with alfuzosin though, because alfuzosin is a modified release, extended release product, and as a result you don't see as much of the adverse effect with that extended release product. So hypotension and syncope are not seen as often. Now with the third generation, you do not see the hypotension, syncope, dizziness as much. It's really not as clinically significant. Those are, remember, our tamsulosin and our silodosin. Adverse effects specific for the third generation include fatigue and ejaculation, or essentially a prevention of ejaculation, flu-like symptoms, congestion, and rarely a syndrome called floppy iris syndrome. In regards to comparison of these drugs, you see here specific bolded information, so I do want you to know the brand names of all these agents except for alfuzosin. Alfuzosin is really not used much from what I've seen in clinical practice, but I do want you to know regarding alfuzosin that it is a second generation and that it is an extended release only formulation. Now with terazosin and doxazosin, those are other second generations. And you see that doxazosin also has an extended release formulation. Even though it does have an extended release formulation, the hypotension risk is still there, even with all of the second generation agents, even though it is less with alfuzosin. With our tamsulosin, you see here that our doses are bolded here. So those are doses that you need to know for practice and for testing purposes. The starting dose of Flomax or tamsulosin is 0.4 milligrams daily, and it can go up to 0.8 milligrams daily, though I've also seen higher doses given in practice, but per package insert and the information that we have available to us, usually these doses should not be titrated past 0.8. For silodosin, or also known as Rapaflo, the standard dosing is 8 milligrams daily. So now that we've talked about our alpha adrenergic antagonist, we'll go through the remaining subsets of symptomatology and classifications of patients. So in regards to patients with a small prostate and a low PSA, and a small prostate here is going to be less than 40 grams or 40 mLs, and a low PSA is considered less than 1.4 in regards to the PSA units. In those patients that have the small prostate and a low PSA, we are going to still give them an alpha adrenergic antagonist. In regards to patients that have a large prostate, however, and an increased PSA, we're still going to give them an alpha adrenergic antagonist to minimize that contraction of the prostate, but we're also going to give them a 5-alpha reductase inhibitor. And our 5-alpha reductase inhibitors include finasteride or Proscar and dutasteride avodart. And remember that finasteride is Proscar for this purpose. You will also see other finasteride formulations out there, such as Propecia. Propecia is a formulation that is used for hair growth in men mostly with male pattern baldness. In regards to what 5-alpha reductase inhibitors actually do for the prostate, they decrease intraprostatic and serum dihydrotestosterone or DHT levels, therefore reducing the prostate size, and this can be done by about 25%. 5-alpha reductase inhibitors are indicated for management of BPH in regards to large prostate sizes, and again, at least 40 grams or 40 mLs, and an increased PSA, or prostate-specific antigen, of 1.4 nanograms per milliliter. One flaw with the 5-alpha reductase inhibitors is that they do take a long time to work. They take about 6 to 12 months to actually see actual effect from them, so it does take some time to shrink that prostate. In terms of adverse effects, one of the main adverse effects of both 5-alpha reductase inhibitors is sexual dysfunction, and that includes decreasing libido, nausea, abdominal pain, dizziness, flatulence, headache, muscle weakness, and then another one that may not be as wanted is gynecomastia, particularly in our male patients. One big contraindication with the 5-alpha reductase inhibitors is patients who are pregnant. Now, you may be asking, Dr. Broussard, why are you talking about pregnancy? These patients are male. And yes, they are, male patients. However, these patients may actually be having sexual intercourse with female patients or other patients. And if a patient who they are having intercourse with has the potential to get pregnant, this can actually be teratogenic to that person's fetus. So if this person is having sexual intercourse with someone who is able to get pregnant, that is highly recommended against, because it is teratogenic. In regards to the teratogenicity component of these agents, it actually can cause ambiguous formation of sexual organs for the fetus. So if a patient has the capability of getting pregnant, it should not, those patients should not have sexual contact with those patients who can get pregnant. If a female or a person of childbearing has or interacts with the 5-alpha reductase inhibitors, they should use protective gloves. And as an extra precaution, it is said that this gloving can be done in a double nature. So the person who is handling the drug, if they are female and of childbearing age, they can actually put double gloves on their hands, so basically 2 layers of gloves. Now, obviously, the patient's agent or patient's partner may be handling the medication themselves, or even a healthcare worker like yourself, particularly if you are female. Now, if you are female, if you are directly dealing with the tablets, I would put gloves on. If the bottle is closed, you are probably okay. However, if you are dealing with the tablets, double glove and be safe, especially if you are of childbearing age or childbearing potential. Um, as you see here, here are both of the 5-alpha reductase inhibitors. You see the starting doses listed here for daily dose and dosing range. They are both the same. There's only one dose for each of them, and these are important to know. Now, in regards to finasteride specifically, as I mentioned before, it can be used for male pattern baldness, and that dosing is actually 1 milligram daily, which is different than the 5 milligram tablets daily. So be aware of that in practice. If you see a 1 milligram daily of finasteride, it is most likely being used for male pattern baldness or any type of other pattern baldness. In regards to the next section of our schematic that you see here, or our algorithm, if a patient has predominantly irritative voiding symptoms, they can use our cornerstone of an alpha adrenergic antagonist with an anticholinergic agent or mirabegron. In regards to our anticholinergics, those include agents such as darafenicin or Enablex, solifenacin vesicare, oxybutynin, transdermal oxytrol, and tolterodine, which is an extended release formulation, in this case Detrol LA, specifically for purposes of using it for BPH. And obviously there are more anticholinergics that are present. However, these are the ones that your text actually lists. The way that anticholinergics work is that they work in patients to block the muscarinic receptor in the bladder detrusor muscle, thereby reducing uninhibited detrusor contractions. And these are used in patients with irritative voiding symptoms, such as increased urinary frequency, increased urgency, and nighttime awakening to use the restroom, or essentially urination at night. Obviously, with our anticholinergics, we have all of the typical anticholinergic symptoms: dry mouth, nausea, constipation, blurred vision, confusion. It's obviously important not to give these to patients with narrow angle glaucoma, as it may worsen that disease state, as well as urinary retention, such that the post-void residual is greater than 150, because if you are giving this to a patient, in those cases, you're actually going to be promoting urinary retention by giving an anticholinergic agent. These are basically given to patients who have increased urinary frequency, who may have just a little bit of urine in their bladder, and then they basically have their bladder respond by going to the bathroom constantly. So anticholinergics are good in terms of these types of irritative voiding type symptoms. And only in terms of these irritative voiding type symptoms. If a patient has a post-void residual of greater than 150 mLs, it's obviously not a great idea, because it will cause more retention of urine in the bladder. Mirabegron or Myrbetriq is another agent that can be used for these irritative voiding symptoms. It is a special agent in that it is a beta-3 adrenergic agonist, which will increase CAMP production, which relaxes the detrusor muscle, which essentially will be overacting in these types of irritative bladder symptoms. So if you relax the detrusor muscle, you're essentially relaxing that muscle that's pushing all of the urine out. It's used in patients with irritative voiding symptoms. It reduces the symptoms, it reduces the urinary bladder's capacity, and it increases the interval between voiding. With this agent specifically, it increases blood pressure. It does cause dry mouth and constipation, though much less than the anticholinergic agents that we also just talked about. It also causes nasopharyngitis and headache. Now, once you have basically gone through and looked at the patients with moderate symptoms, the patient may actually then eventually progress to where they get actual severe symptoms and real actual complications of BPH that can be very, very harmful to the patient. And if a patient is having complications of BPH, one of them that I think of predominantly is acute kidney injury or recurrent urinary tract infections, they probably need some type of procedure done. And this can be a minimally invasive surgery or a prostatectomy to remove the prostate or part of the prostate, such that these complications can hopefully be minimized and treat the patient appropriately. Here is the reference for this talk today. And going back to our case, we have MM, a 68-year-old male who came to the clinic with urinary dribbling. He's had these symptoms over the last few months and feels as if his bladder's full. Testing and physical exams show that he has BPH. His AUA symptom index is 8, and his prostate size is around 30 grams. His PSA is 0.9. So what type of BPH does MM have? The answer here is moderate. So if you remember, mild BPH is a score of 7 or less on the AUA. For moderate, it needs to be higher. And for severe, it needs to be at least 20 or above. And remember that this test is out of 30 points. And obviously, MM has BPH because it says it in the case. So obviously, that last answer is kind of bogus. Question 2, which intervention would be most appropriate for MM at this time? The answer here is actually taurursine, and really any of the alpha adrenergic antagonists can be used for this patient. Finasteride would only be used if the patient had an elevated PSA as well as an enlarged prostate greater than 40 grams. Oxybutynin would be for those irritative type symptoms because it is an anticholinergic agent, and because we have not progressed to severe BPH yet, prostatectomy would not be appropriate. In regards to what is an adverse effect of the agent chosen in question 2, the answer here is hypotension. Hypotension occurs in our second generation alpha-1 antagonist because of the non-specificity and the fact that it works on the vasculature, versus tamsulosin and silodosin, which don't see hypotension because they are alpha-1A specific. Dry mouth we typically see with the anticholinergic agents. Eye discoloration actually was not an adverse effect of any of the agents, and gynecomastia actually can occur with our 5-alpha reductase inhibitors such as finasteride or dutasteride. So that is why those answers are not the best answer here. Hypotension is very common with taurursine, as well as the non-specific alphas, and they can actually be used concomitantly in patients that have hypertension as well as BPH together. That is it for this talk on BPH. If you have any questions, feel free to ask. Thank you and have a great day.